Hello, my name is Dr. Martha Curley. I'm a nurse scientist here at Children's Hospital in Boston, and I'm very excited to introduce to you our guest today for OPENPediatrics, Dr. Lyvonne Tume, who's here from Alder Hey Children's Hospital in Liverpool, United Kingdom. Welcome.
Thank you very much.
Yes. So we're really excited to have you here to talk about the research that you've done in the field of pediatric critical care. As everyone knows, we don't have a lot of nurse scientists who study phenomena of concern in pediatric critical care, and Dr. Tume is one individual who's really made unbelievable contributions to the field, specifically in two major areas. The first area is cerebral hypertension in kids with traumatic brain injury, and the second is a study that you did evaluating priorities of nursing research throughout Europe. So Lyvonne, can you tell us a little bit about your interest in cerebral hypertension?
So I'd worked on an ICU for many years, both with these sort of pediatric neurotrauma patients and was aware that really, doing routine things like suctioning the child and turning the child really led to sometimes considerable physiological instability. So I wanted to look at, so I obviously had a look at the literature to see what was out there, and really there was very little work done in pediatrics, a little bit in adults, and so I wanted to look at what was the impact of these routine nursing cares, suctioning, turning, eye care, etc., on the ICP in these children. So we did this cohort study over 3 years. This was my PhD work, and we were able to describe the effects of particularly suctioning and turning being the most detrimental effects, interventions on these children, which did produce considerable instability, although the recovery time was varied, longer with turning than suctioning. So that was a useful thing. We published that in 2011, and it has since gone into our guidelines and been presented internationally, and hopefully has made an impact on nursing practice.
It's really interesting because it took 3 years to collect data. How many patients did you study?
And that was 25 patients. So, this is quite a rare, it's actually a rare condition, although, it accounts for about 20% of admissions worldwide, neuro generally, but in this day and age, it's not that many patients in the UK coming into units with traumatic brain injury that's severe.
So what really made you ask the question?
Well, as I say, I was at the bedside for many years and still am, one day a week, and you begin to, it's from practice really that you begin to think, how can I do these things that are going to minimise the instability to these children? Because we're really responsible for maintaining physiological stability, and that's the whole nursing and ICU team's role in these children. So things that are going to promote destability, you want to try and avoid them.
So Lyvonne, the patient population, kids with cerebral hypertension, I agree, are so sensitive to the environment and to stimulation and to routine nursing cares, and to observe that things that nurses did really influenced their capacity, their intracranial, hypertension is significant. It's a wonderful study, and so just can you summarize what the major findings were?
So the major findings were that there were 2 interventions. I mean, there's sort of 6 commonly performed interventions, washing the child, eye care, mouth care, turning them, suctioning them. But really the only 2 that produced physiological instability for these children were suctioning and turning, and that was quite pronounced. Suctioning produced a greater rise, but the recovery was quite quick. Turning via a log roll approach was produced less rise, but still clinically significant, over 20 millimeters of mercury, but they had a longer recovery time. So I guess the findings for us is that these are the 2 interventions to really plan carefully, execute skillfully, try and sedate the child more beforehand, and perform them as quickly as possible. And probably we'd said not to do the 2 together, although we didn't test that. And in fact, ethically, we would not be able to do that now. Probably not useful to turn them and suction them together. You're more likely to produce a higher ICP for a longer period.
So at this point, I'd like to pose questions for the international audience. Please don't forget to mention where you're from so we can evaluate practice across the world. The first question I have is who out there specifically has guidelines, policies, or procedures related to suctioning and turning patients who have intracranial hypertension? Do you think the ICP changes had anything to do with CO2, or?
We kept all those confounders, and there were a lot, as you can imagine, were all recorded at the time of the intervention. And you know, no, not particularly, I don't think. They all had the median, you know, CO2 was pretty low on all of them, 36 millimeters mercury. So they were all kept, actually, there were a lot of confounders, but when you look at the management of these patients, the medical management and the way we work, the protocols, they're actually all kept in a fairly similar state in terms of head elevation, you know, cerebral perfusion pressure targets, all this sort of stuff. So, but we did account for that as much as we could. I mean, it's an observational study, and that of course, some of the confounders, of course, can't be controlled for.
There was always lots of controversy on transducers. Where do you put transducers with when you're monitoring intracranial pressure? Any thoughts on that?
Yeah, I mean the argument has always been, you know, where do you put the where do you level it from? We, like many units, I did an audit of practice at the same time around the UK to find out what was units practice around this, because there's certainly no convincing evidence either way in the literature, and so we measured it, you know, as we normally would do from the right atrium, even though the arterial line is clearly and usually in their radial artery.
I was also intrigued with the waveform analysis of intracranial pressures. Did you do anything with that?
No, we didn't actually, and these are all intraparenchymal monitors, which is what is used exclusively in the UK, and I think that's a little bit different over in the US. But you know, sometimes the trace wasn't perfect. It wasn't great, actually, to be able to do that. But that would be a very interesting thing to do. There's been some work done on that in adults, I think, in adult traumatic brain injury.
And then different if you're doing intracranial monitoring versus, you know, ventriculostomy monitoring?
Yeah, absolutely. Yeah, that's right.
Anything else you want to share about that study?
No, I think it was a useful study. I mean, you always look back and think, you know, I wish I'd done something else differently. You know, you learn by doing it, don't you? And if you could go back and do it again, I would do something different. It's still a particular interest of mine, that sort of work, and the impact of particularly suctioning on many patients' instability. At the moment, I guess my interest would be in the high-risk cardiac infants, and you know, suctioning in those children can be, you know, very bad, very dangerous, and certainly can lead to cardiac arrest. We've seen that, and it's been seen in many places. So, I would almost like to do that study again, but in these high-risk cardiac infants.
So, tell us more about the work that you're doing with the high-risk cardiac infants. Anything specific? I understand you're doing something with NIRS.
Yeah, we did a pilot study. A consultant anaesthetist and myself did a pilot study of 10 infants to try and look at, you know, NIRS is not used routinely in the UK. That in some countries, like the US, I think it's commonly used. It's not the case in the UK, and so we were able to study this blinded. So we placed somatic and cerebral nerves on these infants, 5 with single ventricle physiology and 5 with biventricular physiology, and looked at the nerves change over time in the 24-hour period, and that was interesting. We had one child that had an adverse event, which was a cardiopulmonary arrest, after a Norwood operation, and the nerves gave, remember this was blinded, so the clinical team couldn't see, and the nerves gave a very clear trend of about 37 minutes down before the child had this cardiopulmonary arrest. So I think that was interesting work. We've just written it up for publication. It's only 10 infants, it's only a pilot study. It was to really work out how we could collect the data, and we are currently trying to develop a large national trial in the UK, and we're in negotiation with the NIHR about this.
Please don't forget to mention where you're from so we can evaluate practice across the world. Who in the cardiac intensive care units uses NIRS monitoring as a standard of care in their unit? It's really interesting in peds critical care, neuroscientists studying the phenomena of concern in pediatric critical care, and your research has been about the technology-patient interface, both of your studies.
Yeah, yeah. Well, I mean, I guess that's how we work, isn't it, in intensive care? We're very much, as an ICU nurse, part of, it's not just the patient, but it's also the technology that monitors the patient becomes, you know, part of our environment and what we have to deal with and respond to, really. So it's an important thing to look at the effect of things that we do on physiological variables that we have. So much of the care, all the research in paediatric intensive care is directed at medical therapies, and there's very little published research on the impact of nursing cares, yet, you know, it's us that are delivering 85% of the nursing care, or the care, the hands-on care of these children, but very little research directed in that way.
Yeah, the salience of the capacity of the nurse to observe you know, minuscule changes and then be able to quantify that.
Yeah.
So I think that technology at least allows us the potential to do that. So it's really exciting work.
Yeah, yeah.
What's your next one?
Well, this national trial is taking some time in developing. It's a challenging thing. As you can imagine, no one has yet managed to demonstrate that nerves can actually make a difference to patient outcomes. And of course, it's always difficult and challenging trying to study a monitoring device, because it's not just the device, is it? It's what you do with the information after that. So that's a challenge. That's been taking up a lot of my time, but I guess we've just finished the Delphi study, which was a useful exercise, and I guess they've been the two things predominantly taking up my time.
So tell us more about the Delphi study. So it's my understanding that this was a pretty ambitious project, unique to Europe.
Yeah.
So maybe you can talk a little bit about how do you do a Delphi study in countries where you don't really all talk a single language.
Yeah. So this was challenging. It was important. We wanted to define the nursing research priorities as defined by PICU and NICU nurses across Europe. Now, there are obviously 26 countries in Europe, not many of them speaking English. So we wanted to do this, and we certainly didn't want to exclude the nurses who couldn't speak English, because that would exclude a lot of nurses in Europe. So we used electronic software, SurveyMonkey, and has some translation facilities in terms of, you know, the survey itself, but obviously won't translate the questions. So we had a lead translator per country. That was a nurse where we could find them, or not. It was a doctor. Sometimes a very senior doctor, but they were our contacts and they agreed to do it, so we used them. And they would translate the survey, or there's 3 rounds of the survey, so in fact 3 surveys, into that language, and we would get the responses back. So it was challenging, but actually really important, because there was an adult Delphi done across Europe, and they had only used the nurses who could speak English, so that sort of selects out a particular group of nurses who are, you know, usually senior nurses and not actually always bedside nurses. So.
Did all 26 countries respond?
No, we had a response from 20 countries in the end, which wasn't too bad. We were quite happy. We did make every effort to try and get contacts per country, but there are some countries where we just had no contacts and couldn't get anyone. But yeah, I mean, we were fairly happy. We aimed for 8 nurses per country, and they would be a mix of roles. So they would be clinical, 2 clinical bedside nurses, 2 education or training nurses, 2 management head nurses, and nurse scientists or research nurses if the country had them. And so to try and give us a broad mix of role types within that. So that's what we set out to do. And actually we got, in some countries, 2 countries in particular, we got more than 8, but that was Italy and the UK. But generally we got a mixture. Our sampling matrix worked fairly well, and our demographic details at the end were good. It achieved really what we wanted, which was a mix of nurses across as many countries as we could get, and various roles.
What was the difference between the 3 distribution, the 3 rounds?
So the first one, it's modified Delphi. The first one was very qualitative and open-ended. So you got demographic data from these participants, age, you know, PICU type, that sort of thing, years of experience, and then we asked them really just one question. You know, give me the 3 top research priorities, a minimum of 3 and maximum of 5 research priorities that you think are crucial for PICU nursing in Europe. We asked them to be as specific as possible, and then, you know, so it was open-ended, free text. We got that back. There was 4 of us doing this study, so myself and my colleague Jos Latour with the paediatric people, and we analysed that data, content analysis independently, tried to categorise it into main categories, so domains, and then a number of research statements that fitted within these domains. Then from that, you generate those research statements and domains, go out as a questionnaire, and the nurses are asked to rank on a Likert scale of 1 to 6, 6 being the most important topic, what they thought was the most, rank each of these things, and then you get that back. That's quantitative. You can look at mean standard deviations of the scores of any of these items. We decided a priori that if anything scored less than a 3, mean score, less than 3, that would not be consensus and we would delete that item, but in fact that didn't happen. All the items and all the statements came back as scores over 3, so we kept with them, and for the round 3 you send out the same statements and scores, but the group score and standard deviation is beside that. So then they're asked to re-rank these statements and domains in light of the group response, and then you can analyse that inferentially as well, look at the change between round 2 and round 3, and also the effect size. So that was useful, and you end up with a ranked list of domains and statements, research statements.
Have any of you ever participated in survey research, and specifically questions around identifying priorities of research in your area of the world? All right, so tell us what was the most important items noted.
So there were 9 research domains, and in order these were clinical nursing care practices, pain and sedation, quality and safety, respiratory and mechanical ventilation, child and family centred care, ethics, professional issues in PICU nursing, hemodynamics and resuscitation, and trauma and neurocritical care. And then within them there were obviously 47 particular specific research statements, but there were 7 that scored a really high score, mean score over 5. And these were improving end-of-life care for children and their families, communication and decision making around foregoing and sustaining treatment in the PICU, effective interventions to reduce and prevent pain, the effective education and training methods on nurse competence and knowledge, interventions to reduce healthcare associated infections, identifying appropriate nurse staffing and recruitment strategies, and identifying and improving strategies to improve evidence-based nursing practice, so getting evidence into practice. So that was really interesting actually. They were the top scoring statements, and yeah, we were not surprised necessarily by these statements. In fact, they weren't actually that dissimilar to other studies published in different time periods and in adult intensive care. But they were really important. It was an important exercise to do to really set the agenda for nursing research in Europe for the next sort of 5 to 7 years. And our plan was that this would be developed into a roadmap, if you like, for the society, the European society, and to guide us in this agenda.
So are there mechanisms in Europe that help support nursing research across the European countries?
Not particularly, but there is the European Society of Paediatric and Neonatal Intensive Care is an organisation. It certainly is probably the only one that will facilitate collaboration between countries, but not all countries are represented in this society. But it's certainly one of the avenues with which, probably the main avenue with which we can guide research within Europe, nursing research.
So given your findings, what would you anticipate for people to do with this?
Well, I think it's going to assist the nurse researchers, of which there are quite a few of us, but often working in little pockets of areas, so pain and sedation, whatever, this and that, but actually to try and come together and say, well, these are the priorities, so where can we, which of these should we work on? So I think it'll help us in trying to, it can't help, and it can probably only help, assist us in trying to get research funding across Europe, which is challenging and increasingly competitive, of course. So I think those things will help mainly with that, and to bring people together to, help with more collaboration between groups, research groups within Europe.
It's interesting to note that the top 2 priorities were related to ethics.
Yeah, and end-of-life care, and I think That's interesting. I mean, certainly PICU has changed a lot in 20 years that I've been working in it, and now I think, certainly in our hospital, 98% of deaths in the hospital actually occur in the PICU. I think that was probably not that dissimilar to other places, and so even though none of us went into this as thinking, we're experts in palliative care, that was always for the oncology people. Actually, we have to be, and it is a big issue. Because they will die in the ICU now. They don't tend to die on the wards. People just don't let that happen. So actually I think it probably reflects the fact that there are more patients dying on the ICU, and the challenges that are associated with that for nurses, and dealing with that, dealing with the family and all that sort of stuff, and trying to make the death the best death that they can, and it's a challenging thing. So that's interesting, yeah, it is. There is actually an ethics group section within ESMEC, and that's led by a nurse, Jos, but primarily with medical members. So I think it's an interesting thing, and they've done some work, I think, as well in the past with end-of-life care practices amongst European countries, because there are some differences between Southern Europe and Northern Europe.
It's interesting to note as well that the National Institutes of Nursing Research in the United States funds, or a major funder for palliative care. Right. And so I think it's always been aligned with nursing, but it's always good to see that, surveys that are taken systematically can identify those issues as being a primary concern across the board in Europe. So absolutely. It's pretty interesting. And then also the pain, the pain, and also the safety movement.
Yeah, absolutely. I mean, I think Delphi always reflects the context in which it's done, the time and the, so some of the things that come out, of course, safety, quality and safety is a big issue. You don't know how much that exists across Europe, but clearly it is an issue across Europe and other countries as well. So that probably is very, a thing of the time, which is the right thing. But yeah, I mean, clinical nursing care practices were actually #1, and I think that shows you that really everything else is there, but really these nurses do prioritise clinical nursing care practices as a research priority for them. And that's interesting because, as I said before, there's very little work, published work on nursing, clinical nursing care practices in comparison to the bulk of, I mean, there is some, but of course in comparison to the bulk of work produced in paediatric and critical care, the dominant theme is one of medical treatments, isn't it? Medical therapies. So,
can you talk a little bit about your role?
Yeah.
You mentioned that you work 1 day a week in a staff position. Yeah. Talk a little bit about that, and also talk about what it's like for your unit to have a nurse scientist on staff.
Yeah. So I've always maintained throughout my career at least a day a week on the ICU to maintain my skills and credibility, and I like doing it, And I continue that through when I did this job. So I now work half-time for a university as an academic position and a research fellow, and then half-time for the hospital. So in that half-time I do a clinical shift, but I also do other things for them, practice development, trying to get evidence into practice, guidelines, assist people with writing, that sort of stuff. But the clinical role is really important. I like doing it. I think people like having me on the unit. I'm certainly an extra pair of hands, and that's always a good thing on an ICU. You're always popular. So I think, I think they see you, I guess that's the other perception, isn't it, is that you're not just someone that's in an office, you are someone that they do see, do the job 1 day a week. And you're not perfect like anyone, and although I'm quite a senior nurse on the unit, and but it's important because actually those sort of research questions, more research questions for me, come out of clinical practice, and you think, why are we doing this? Or, I'm sure there's got to be a better way to this. So it's really important, and it's a nice role that I've been able to do.
So one final question, and then we'll stop. So there's a lot of emphasis right now on interprofessional collaborative research. Yeah. In fact, here at the NIH, there's multiple principal investigator mechanisms. It's really important for multiple disciplines to come together and hit hard on a problem. And certainly within the pediatric intensive care unit, we practice in a interdisciplinary way. Yeah. So you know, are you experiencing that wave of enthusiasm across Europe, or is it something still nursing does their own research and, you know, not really part of an interprofessional team, never mind lead an interprofessional team of researchers?
No, I think in the UK it's certainly not like that. It certainly is very much a collaborative approach. As you say, intensive care is a team approach, and I think that's the same within certain countries like the Netherlands. Very also strong on nursing research. Other countries it's clearly variable. I mean, you know, some countries there are no nursing research roles, but you know, for us, I mean, you know, I work on 2 projects with one of the consultant anaesthetists. I lead the project. I approached him because he's got a lot more experience with nerves because he's a cardiac anaesthetist. But we've worked together on a couple of things. I lead a group around the UK to look at this, and I'm the only nurse. The others are all consultant physicians in intensive care across the UK. And I think, you know, it's been, yeah, it's changing, definitely. I think they do think, well, you know, you've got the time and you've got the role to do this, then why can't you lead this, you know, if you've got the skills to do it. But, you know, I need them as well. We have to work together, and, yeah, I mean, it's a really important thing, I think. So, yeah, no, certainly is what we would do in the UK. And I think probably in the Netherlands as well.
You mentioned the UK and the Netherlands, so it's not across the board throughout Europe to have Delphi prepared neuroscientists on staff?
No. I think when you looked at this, Delphi was very enlightening, because I think, you know, in some countries there are no nurse science roles. In some countries there were no education nurse roles, you know, which I think tells you a little bit about how the specialty runs. So you know, there are, so Scandinavia is quite good. They have quite a lot of nurse scientists, I think. I don't know what they're called, but, you know, PhD prepared nurses. Germany has some, but really the Netherlands and the UK probably are the highest proportion of nurse scientists within Europe. The Dutch are very good at that, and of course they, you know, their PhDs are a little bit different. In Europe, you know, they're PhD by published works. That's how they do them, and they have to be written in English. So of course that, you know, sets the tone for how they do things. It's very rare in the UK to have those sort of PhDs. Ours, you can, but it's not very common. Most are just standard PhDs research. But yeah, no, certainly collaborative research. I think research is crucial, really. I mean, that's how we work, isn't it? So why would we research things entirely separately?
And I think it's interesting to note that we met each other at the Royal Federation meetings, and then we continued our relationship with a bunch of other doctor-prepared neuroscientists across the world through our go-to meetings that we have. And what we do is we pick a topic every month, every other month. It's a friendly environment because there's not a lot of neuroscientists who are doing the type of research that you're doing. And to have colleagues who you can vent, you know, a question with, develop the question, and then move and look for collaborators. And with that, I'd like to close and thank everyone for their time and their participation and tuning in to Open Pediatrics. Thank you.